Correct. This is good.
Yes.
Yeah. I'll just stay here and I can whichever way. Frank, you tell us when you're ready.
Yeah. All right, well, let's get started. Thank you all for coming out tonight. My name is Kevin Lutsky. I'm a hand and wrist surgeon with the Rothman Institute, and I'd like to welcome you here and also to people online and watching and listening at home. So this is going to be the Rothman Institute Community Education Seminar on minimally invasive treatment for common hand surgical conditions. And the four things that I'm going to talk about today are very common problems you may have heard about: carpal tunnel syndrome, cubital tunnel syndrome, thumb arthritis, and something called Dupuytren's disease. There are many traditional approaches that we've used for a long time to treat these common conditions, and some newer, quote unquote, less invasive options. And so the question is, are these really beneficial? Are these evidence-based, or are they just kind of marketing ploys to say, hey, I can do things through a smaller incision, and is less really more? So carpal tunnel syndrome is very common, and you probably know somebody who has it. Many of you may have carpal tunnel syndrome. You've probably heard about it. It's caused by pressure on a nerve at the wrist. It's called the median nerve at the wrist. The signs and symptoms are related to compression on that nerve in the hand. And so you can see here up on the top part of the screen here, this is the cross-section of the wrist. This is the carpal tunnel. It's made up of bones on one side and then soft tissue, a ligament on the other side. And through that tunnel, there are 9 tendons and a nerve, the median nerve. And so when pressure builds up on that nerve, you start to get the symptoms. What you see often is numbness and tingling in the hand. Most commonly, it's the thumb through the ring fingers. People often wake up from sleep at night. You have to shake out the hand and that sort of thing. Other things that can affect it: driving a car, using vibrating equipment like a jackhammer or lawnmower. Sleeping, very commonly, people tend to sleep with their wrists in a flexed position. And doing that increases the pressure in that tunnel a lot, really increases the symptoms. First thing we do for carpal tunnel syndrome typically is non-operative treatment. So as long as there's no signs of advanced nerve compression, if there's not a lot of weakness or wasting of the muscles here or changes in sensation, we try and do things non-operatively to help with the symptoms. The first thing that we try is a splint at night to try and keep that wrist in a nice straight position and keep the pressure off of the nerve. Other things people try with varying degrees of success: anti-inflammatories, warm compresses, vitamin B6, and sometimes a cortisone injection, which I'll talk about. So with the splint, you really want to keep your wrist in a nice straight position. And if any of you have carpal tunnel syndrome or gone to the drugstore to buy a carpal tunnel splint, there's a metal bar in that splint that kind of bends the wrist back. What I usually advise people to do is to straighten out that metal bar to keep your wrist in a nice straight position. I don't know why all the splints on the market that are designed to treat carpal tunnel syndrome are suboptimal. So if you do that, you just want to take the bar and kind of straighten it out to keep your wrist in a nice straight position. Helpful. They're typically successful pretty well for the short term. They're not very long-term treatments for carpal tunnel syndrome. Numbness and tingling in the hand, pinched nerve, systemic problems like diabetes or hypothyroidism. Sometimes it's not clear if this is coming from. If so the traditional surgical treatment for carpal syndrome is called an open carpal tunnel release. The traditional that I showed you before. Basically, out of the tunnel. Nothing in medicine. 98% is, just about as good as you can get. It's typically a very good, very effective medication. More people are got the carpal tunnel release and tunneling around the ligament using a knife blade while you're visualizing it. And there have been a lot of studies looking at the differences between open and endoscopic carpal tunnel release. And the bottom line is both are very safe, effective procedure. Very low complication rates with both of them. Maybe a little higher with endoscopic. Endoscopic carpal tunnel maybe is the American Academy of Orthopaedics surgery guidelines and a review on all of these procedures. And basically what they found was overall no difference in the two procedures, particularly as you go out in the longer term. Endoscopic carpal tunnel release has a little bit less pain at 12 weeks and scar complications, pinch strength. Open carpal tunnel release has a decreased risk of nerve damage, typically reversible, and it's less likely that you would need a revision surgery or a repeat surgery. Away even from that large traditional open approach to what's called a mini open technique. And rather than making a big incision all the way across the wrist crease, we make a smaller incision, 2 to 2.5 centimeters. This picture here actually is even a little bit bigger than what I typically do, but does not cross the wrist crease. It allows us to look directly at the ligament. We can extend the incision if we need to for whatever reason to see safely. And overall, carpal tunnel syndrome, I tell patients, this has excellent results. Carpal tunnel release is the best surgery that I do. It's generally a very good, very safe, reliable surgery. Patients are generally very happy with the outcome. But we can go to the next slide. That's it. So I think one of the important things in treating carpal tunnel syndrome is to define the expectations from the outset. And I'm really surprised how many patients I see who tell me they've had or they know friends who've had bad experiences with carpal tunnel release. Because on my side of it, I see really great outcomes with carpal tunnel. And there are a lot of people out there who seem to have anecdotally bad experiences with it. And I think part of it is defining your expectations at the outset. Oftentimes, people are waking from sleep with the carpal tunnel. Carpal tunnel release is very good at treating the nighttime symptoms. And carpal tunnel release is very good at preventing the nerve compression from continuing to worsen, but it's not necessarily going to give you back muscle strength or sensation that you've lost as a result of permanent nerve damage. And sometimes that can be hard to tell before surgery. And so some patients, I think, have carpal tunnel release, and if that sensation doesn't come back, they feel that the surgery is a failure. You just have to, have the discussion with your surgeon beforehand that sometimes not all the sensation comes back. What we're trying to do is prevent it from getting worse and to help with those, really irritating nighttime symptoms. If we can do that, the surgery is actually a success. If that sensation comes back, that's even better, but it doesn't always. Cubital tunnel syndrome is similar to carpal tunnel syndrome in that it's caused by pressure on a nerve, but it's pressure on a different nerve. And cubital tunnel syndrome is caused by pressure on the ulnar nerve at the elbow, or your funny bone. This is looking at the inner portion of your arm and elbow, and this here is the ulnar nerve, or the funny bone at your elbow, and it comes down here behind the medial epicondyle, which is that bony prominence of your elbow, and it can get compressed in this area, which is called the cubital tunnel, and it's compressed by the soft tissues called the cubital tunnel retinaculum. Again, people will often sometimes complain of a feeling of weakness or clumsiness. The numbness and tingling, as in contrast to carpal tunnel syndrome, in cubital tunnel syndrome, the numbness and tingling usually involves the ring and small fingers, sometimes this portion of the hand. And the reason this happens is, again, with the elbow, the nerve runs through this tunnel. And when you flex your elbow, which again, people commonly sleep with their elbows flexed. When you sit at a desk, you often have your elbows flexed, or in the car. What happens is that ligament actually becomes tighter, and so it compresses the nerve. Ways we diagnose this, sometimes we'll tap on the nerve at the elbow, and you can feel often a little electric jolt going out into your fingertips, again, similar to when you hit your funny bone. A lot of people have that anyway, so that if you try that on yourself and you feel a little jolt, don't be concerned. But in people who have the signs and symptoms of cubital tunnel syndrome, it's a very sensitive test. We'll do something called an ulnar nerve compression test, where we'll just put some pressure on the ulnar nerve at the elbow and see after 30 seconds or so if that reproduces the symptoms, which often it does. And much like carpal tunnel syndrome, for people with mild nerve compression, the first things we try are non-operative treatments. And I think that's very reasonable before considering surgical treatment for most of these problems. As I mentioned, flexion of the elbow puts a lot of pressure on the nerve. So the things we try and do from a non-surgical standpoint are to do things to try and limit that elbow flexion. And we can either use a rigid splint to try and keep that elbow in a nice position, or a soft elbow pad to try and help keep you from bending your elbow up, especially at night. But in people who have unchanged or certainly worsening symptoms, then that's when we start thinking about surgery. And again, the goal of surgery in this instance is to decrease the pressure on the nerve and give the nerve an opportunity to recover. There are a variety of different treatment options for cubital tunnel syndrome. And we'll talk about some of these in situ decompression and a variety of transpositions. More recently, some people are doing endoscopic cubital tunnel releases as well. So just a disclaimer, got some surgical pictures. If anybody's queasy, now's the time to look away. So this is called an anterior transposition of the ulnar nerve. And so this is looking at the inside portion of the elbow. Again, normally the ulnar nerve runs back here behind the medial epicondyle. And what we do when we do a transposition is we take the nerve and we move it to the front part of the elbow. And we can either do what I've done here, which is put the nerve below the muscle. It's called a submuscular transposition. Or sometimes we'll take the nerve and put it on top of the muscle, but below the skin layer here is called a subcutaneous transposition. And you can see that that's a pretty big surgery. It's a lot of dissection. We have to elevate the muscles. We have to mobilize that nerve. And afterwards, we need to keep the soft tissues protected. So people are in a splint typically for 4 to 6 weeks. We can do motion outside of the splint, but we try to be protective of the elbow afterward. And this is our minimally invasive option of choice now. It's called a simple decompression. And so what this involves is, rather than taking that nerve and moving it all the way to the front part of the elbow, we make a smaller incision and just free up the tissue on top of the nerve so it's no longer getting compressed. And you can see, obviously, it's a much smaller incision, much less soft tissue damage, and much less trauma to the area. Patients don't need a splint afterwards. We try and limit heavy lifting, usually for 4 to 6 weeks. Sometimes people feel so good they go back to lifting earlier than that. But certainly we can be much less protective than when we do the larger transposition procedure. And there are a lot of studies looking at the differences between these procedures. I'm not going to go through all of them, but the bottom line is what we found is clinically, there's really, in terms of the outcomes, no difference between that big procedure, the transposition procedure, and the ulnar nerve decompression. But what we do see is a couple of things. Number one, takes a lot less time, on average 13 versus 31 minutes for the smaller procedure. Decreased complication rate, especially wound-related complications. You can imagine having a big wound on the inside portion of your elbow puts you at a little bit more risk for complications than that smaller wound. And we know that if the smaller procedure doesn't work, typically 5 to 7% of the time, we can always go back and do the bigger procedure down the road, generally with pretty good outcomes. So for me, I tend to favor the simple decompression. I think it's a very good procedure, particularly with people who have mild to moderate symptoms. But one thing we look for at the time of surgery is sometimes the ulnar nerve doesn't stay where it belongs behind the elbow. When you bend the elbow up, the nerve does what's called subluxes. It slides to the front part of the elbow. And if that happens, we can't do the smaller ulnar nerve procedure. We have to do the transposition. And we prepare for that at the time of surgery. We make that determination at the time. All right, so another very common problem is thumb carpometacarpal or basilar joint arthritis. This is a very common problem. The thumb carpometacarpal joint, which is the joint at the base of the thumb where the thumb sort of meets the hand here, that's the most common joint in the body to develop arthritis. Pretty much everybody gets arthritis at the base of the thumb. Not everybody's symptomatic from it, but just about everybody with time will get arthritis. And what people commonly feel is pain with using the thumb, pinching, gripping, grasping, those sorts of things. Classically, the activities are opening jars, turning doorknobs, turning on the car ignition. And you can go to the next slide, please. And so what we'll see is tenderness over that joint, either on the back part of the thumb or often here, which is called the thenar eminence, that muscle tissue here at the base of the thumb. Sometimes in the office, we'll do what's called a grind test. Move that joint back and forth against each other to see if that reproduces the pain. And what you see often, obviously, is pain. You can see deformity of the thumb. Sometimes there's a pretty noticeable prominence at the base of the thumb. Sometimes people start to develop hyperextension of this joint here to compensate for the deformity at the base of the thumb. And again, like the problems I mentioned earlier, the first things we try and do are conservative, so non-operative treatment. And it's really important to know that the way the x-rays look does not correlate to how patients feel with arthritis at the base of the thumb. You can have very, very bad looking arthritis on x-rays, very advanced severe arthritis on x-rays, and have no symptoms or minimal symptoms. And sometimes people can have lesser degrees of arthritis on x-ray and be much more symptomatic from them. So it's important that we treat you, the patient, and you treat your hand rather than the x-rays themselves. And so the things we do initially, splints, sometimes therapy, anti-inflammatories, cortisone injections, and we consider surgery when those non-surgical treatments don't adequately address the symptoms. So again, some surgical pictures coming up here. There are literally over 100 different described techniques for treating arthritis at the base of the thumb surgically. The classic technique is called a ligament reconstruction with tendon interposition. And it's done through a fairly large incision here, overlying the base of the thumb. And what we do in that procedure is we remove the arthritic bone and then use a tendon at your wrist called the FCR tendon to typically through a drill hole in the metacarpal bone to support and reconstruct and cushion that joint. But it involves a lot of dissection, postoperative discomfort. If you have carpal tunnel syndrome, the swelling afterwards can exacerbate that, and mobilization typically for 5 to 6 weeks after the surgery. The most minimally invasive treatment that we have for thumb arthritis at the base of the thumb is arthroscopic treatment. And this is a very good treatment for arthritis at the base of the thumb with a lot of limitations. And so the indications for treating thumb arthritis arthroscopically are the joint has to be nice and stable. It can't be significantly out of place. There can't be a lot of deformity to the thumb, and arthritis on both sides of the trapezium bone, which often you see in later degrees of arthritis. But it's a very safe, effective treatment. Basically, what we do is arthroscopically, through a couple of small poke holes here at the base of the thumb, remove just a portion of that trapezium bone. And then sometimes we'll interpose a little soft tissue of some sort to act as a cushioning in the joint. This is just a diagram of the bigger procedure, the ligament reconstruction tendon interposition. You can see basically this tendon we take and pass through drill holes and then use a little bit of a cushion in the joint. And there you can see an X-ray of somebody who's had a similar type procedure. That arthritic bone is now removed. There's a space there where that trapezium bone used to reside. That's a much bigger procedure. The arthroscopic surgery has been shown to have pretty good results. This was in 1996. 25 out of 33 hands had complete pain relief. A few patients with persistent pain required second surgery, and most of those were satisfied after the revisions. A couple of additional studies, again, showing good results with the arthroscopic surgery. But the traditional open surgery has very good results too. Very good long-term results, 90 to 95% satisfaction rate, pain relief, high percentage improvements in grip strength versus preoperatively. It can take a long time to see those improvements, sometimes more than 5 years, and results in postoperative discomfort and immobilization. We've started to move sort of towards a middle ground. Some people are doing just the trapeziectomy alone, meaning just removing the arthritic bone and not doing any of the reconstruction or taking the tendon and weaving it through a tunnel. What I tend to do is again, sort of a compromise between those techniques as well. I don't use the FCR tendon, which is this one of the tendons that lets you. Again, there are multiple different ways of doing the procedure, but a lot of us have started to move away from this the LRTI. All right, the last thing I'm going to talk about is Dupuytren's disease. And Dupuytren's disease occurs when the normal tissue in your hand turns into abnormal cords, which cause the fingers to draw in and contract. There is a genetic component to it. It's called autosomal dominant with variable penetrance, meaning it's not as straightforward as blonde hair or blue eyes, but it does have a genetic component to it. It's also associated with diabetes, people with seizure disorders, alcohol, that sort of thing. And so this is what happens. This is the normal connective tissue in the palm. If you were to remove the skin, this is what you would see. And in Dupuytren's disease, that normal tissue turns into thickened, contracted bands that cause the fingers to curl in. And this is what it looks like clinically. So there are a variety of treatment options for Dupuytren's disease. First of all, you don't have to do anything about it. Which is the disease before the fingers have become contracted, we don't do anything about it. Because we don't have a cure for Dupuytren's disease itself. What we treat are the contractures associated with it. So if the fingers are not drawn in, if they're not curled in like that, we don't treat it. Steroid injections sometimes can help decrease pain if the nodules associated with Dupuytren's are painful. That's unusual, but it can happen. The non-surgical or less invasive options that I'll talk about are something called needle aponeurotomy or collagenase. And the surgical treatment options are called fasciectomies. So in general, when we start thinking about treating Dupuytren's disease in any fashion, we look at this joint here, this is called the MCP joint, and we look to see about a 30-degree contracture here of that joint. Some people say any contracture of the middle knuckle here, that's called the PIP joint, or 30 degrees if we're going to measure it. We also do something called daylight sign. So if you can look through the fingers from the side and you can see daylight through the fingers, that's an indication that surgery is indicated, or a positive tabletop test if people can't put their hands flat down on the tabletop. So percutaneous fasciotomy or needle aponeurotomy is a nice option. And basically what we do, and we can do this in the office, is we use a very small needle to basically cut or rupture that cord to release the tether on the finger and straighten out the finger. A lot of studies looking at the safety and efficacy of this. What we can see is that at the MCP joint, again, this knuckle down here, about 80% improvement. At the PIP joint, a little bit less impressive, 65% improvement, but a pretty high recurrence rate, almost 60% at 3 years. Another study looked at this with a 45% recurrence rate after about 5 years. Collagenase goes by the trade name of Xiaflex, and you may have seen ads for this. They have advertisements in newspapers, magazines, they're all over the place. And basically what that is it's an enzyme that we can inject into the cords, and it does something pretty similar to the needle in that it enzymatically cuts or ruptures the cord. And that's pretty good short-term results. Again, similar to needle aponeurotomy at the MCP joint. 77% improvements at the PIP joints, about 40%. So better at this joint here, at this knuckle, than at this knuckle, but still, reasonable results. But the problem with collagenase, much like needle aponeurotomy, is recurrence. 5 out of 27 recurred at 2 years in this study. 4 out of the 6 recurred at this joint in this 2010 study of 8-year follow-up. And collagenase can cause some complications, cause swelling, bruising, pain, and tenderness. It's expensive and sometimes can require up to 3 injections per cord. Now, most insurance companies will cover that cost, but it's still a pretty high societal cost, particularly when you consider somebody who may have multiple finger disease needing $10,000 per finger, starts to be not insignificant. All right, some more surgery here. So this is the sort of the standard surgical treatment, and this is called a partial fasciectomy, and it involves making an incision along essentially the entirety of the finger and removing that cord. And that's been sort of the mainstay of treatment for Dupuytren's, had been the mainstay of treatment for Dupuytren's for quite some time. And as you can imagine, has a reasonable complication rate, up to about 17%, bleeding, injuries to the nerve, those sorts of things. And again, has a pretty high recurrence rate, about 50% in 5 years. So here's the sort of just a little cheat sheet. So needle aponeurotomy or percutaneous fasciotomy, again, pretty high recurrence rate. All of these treatments are going to have high recurrence rates for Dupuytren's, and that's one of the problems with not being able to cure the disease. But about 50% for most of these, as you go out longer, they're going to have higher recurrence rates. Needle aponeurotomy costs very little, uses a small needle. Collagenase is a pretty high cost. Partial fasciectomy has surgical operating room time, recovery, etc. All right, so just to finish up, again, I think the take-home messages are, first of all, non-operative treatment is important and can be effective in treating a lot of these problems. And definitely want to make sure that when it's appropriate, we treat these non-operatively initially, because many people will feel better with conservative care. But surgical intervention can be very successful in the appropriate patients with the appropriate indications. Some of these less invasive techniques can be just as effective as the traditional big open techniques with the potential for less morbidity, but you have to weigh the benefits against the potential risks, particularly here, as I mentioned, in the case of endoscopic carpal tunnel release, and something I didn't talk about, arthroscopic tennis elbow surgery. I think that we need to have you need to make sure you have an open discussion with your surgeon about these options, and choose a technique that's going to be most appropriate for you. And just remember that it's not always the case that less is more. Sometimes the more invasive, quote unquote, more invasive techniques may be the most appropriate. For me, this is just sort of how I think about things. In terms of carpal tunnel syndrome, I think both the traditional approach is reasonable in some patients. I tend to favor the less invasive mini-open endoscopic carpal tunnel release is perfectly fine. For cubital tunnel syndrome, I definitely favor the less invasive decompression. For thumb basal joint arthritis, again, depending on the specific situation, I like doing arthroscopic thumb surgery when it's appropriate and indicated. That is the minority of patients, though. And so the more traditional open approaches are reasonable, although again, we've sort of moved away from the ligament reconstruction procedures. And for Dupuytren's, I definitely favor the less invasive techniques. I happen to like needle aponeurotomy, but definitely we've tried to move away from the big surgeries for Dupuytren's. Thank you very much for your attention. If you have any questions, please let us know. Yes, sir.
In a minimally invasive ones, or before that, the non-operative care, do you recommend any particular creams, ointments, NSAIDs that seem to work better than others?
The answer is yes and no. Sometimes it's a little bit of trial and error in terms of finding something that will work for you. I don't have a good medically based explanation for this, but some people have a better response to Motrin versus Advil versus Aleve versus Tylenol. And I don't know why that is, but generally I'll recommend to people, try a variety of things to find something that works for you. I happen to like Aleve because you only have to take it twice a day. And so I think it's a little bit easier to remember. It's, you don't have to think about it in the middle of your day to take it. You can just take something once in the morning, once in the evening, but that doesn't work for everybody. And so sometimes it's just a matter of trial and error. In terms of the topical treatments, a lot of people tend to like the Voltaren gel, which is basically topical Voltaren. Again, sometimes it's just a trial and error thing. It works for some people, not for others. The biggest problem with the anti-inflammatories tends to be stomach upset. And even the topical anti-inflammatories like Voltaren gel can cause that. Yes, sir?
Where does meloxicam or Mobic fit into it?
Same thing. It's a it's a trial and error. It's Mobic works wonders for some people, does nothing for others.
Because you can't take it consistently.
Any of the anti-inflammatories, and the longer you take them and at the higher doses, those can increase the risk for. Oh, sorry, I wasn't repeating the question. Sorry. Those can increase the risk for kidney issues, stomach issues,
I
those sorts
believe
of
as well. If you
And-
take it every single day.
any of the anti-inflammatories. Exactly. So I usually recommend to people, if you're going to take the anti-inflammatories, you try and take them for a short but dedicated period of time. So there's a
At average, you can't do that.
What's that?
You can't do that at average, once in a while.
Well,
That's not possible.
no, but you can take things for a week or 10 days, that sort of thing.
And then what happens after that? And what happens after 10 days?
Yeah. So
And what happens after 10 days? And what happens after 10 days? That you
The
don't,
pain comes back.
the pain comes back.
Yeah, sometimes.
What
sometimes
do you mean sometimes? It does, all the time.
well,
We're not your age. Just think about it. Just think like your average.
well, yeah. I mean that's part of the reason we try things like steroid injections. But what I will tell you is that's not entirely true, because sometimes, as I mentioned to you before, for arthritis is a good example. A lot of people have arthritis, but not everybody's symptomatic from the arthritis.
Right.
What happens sometimes is that arthritic joint becomes inflamed. And so if you can get somebody through the inflamed phase,
Right.
you can get through to a point where it no longer hurts. It's not going to change that you have arthritis. And so sometimes taking the anti-inflammatories for a short but dedicated period of time is enough to get you through that inflammatory phase. It doesn't work for everybody. But,
Yeah, I know, I understand what you're saying.
There's a such a thing on my hand was, they said it was not broken, but the ligaments have to heal.
Mhm.
Now it's almost 3 months. And I still have the shooting pains
Mhm.
and cannot bend it all the way.
Yeah, I mean, it's hard for me to comment specifically on your hand without knowing the specifics of the situation. Ligament injuries in the hand, I think, are very frequently underestimated. And sprains, which are injuries to the ligaments, take a long, long time to get better.
They do.
Absolutely.
How do you diagnose the arthritis in the thumb? Is that through a MRI or an X-ray, or do you just look at it, or?
So the question was, how do we diagnose the arthritis in the thumb? So it's for a variety of things. Number one is the history. Someone's saying, I have pain at the base of my thumb. It's worse when I open jars, turn doorknobs, that sort of thing. We do a physical exam. We test to see, is that the spot that hurts you? Is it tender here? Is it tender in some other places that can also cause pain in the wrist or hand? And we say, you know, is there arthritis on the X-ray? We don't need an MRI to diagnose arthritis. And it can come and go. For a total of about 4 weeks after the surgery, and then a removable splint, typically for 2 to 4 to 6 weeks afterwards. Everybody's a little bit different in terms of their recovery.
And months after that, the pain goes away.
And then it can take a long time for the thumb arthritis surgery to really reach the maximal results. It's rare in my experience to have patients who have prolonged pain for months and months and months after that surgery, but it can take a while.
For the cubital tunnel syndrome, my girlfriend had a nerve test or something. Do they still do that? Or they do?
Yeah. The nerve studies or EMGs are very, I don't really mention that too much, but nerve studies or EMGs we use very commonly to help diagnose cubital and carpal tunnel syndrome. Carpal tunnel syndrome very, very commonly will show up on the nerve studies. If you have carpal tunnel syndrome, most likely you're going to see something abnormal on the nerve studies. Cubital tunnel syndrome doesn't always show up on the nerve studies, so we use a combination of the nerve studies, the exam, the history, symptoms, those sorts of things. Thank you.
I've been getting, on and off now for many years, cortisone injections. Do they have to be stopped for some period of time before you can have the surgery?
I usually suggest if you're going to have the surgery to wait around 4 to 6 weeks after your last cortisone injection. There's no real scientific data behind that recommendation, but in theory, the cortisone injections can have some effect on wound healing, on resistance to infection, and those sorts of things. The other thing is, I think you want to give it a chance to see whether the injection is going to have worked for you. And sometimes it can take 4 to 6 weeks before you see the full.
Like I said, I've been having them now for about 4 years, and they usually last about 4 months between both hands. Now, it doesn't do anything for my left hand at all. I'm sitting here doing absolutely nothing, and I'm in pain.
Yeah.
So,
Yeah, I generally would wait, a good 4 to 6 weeks before the last injection before doing anything surgical. Okay. All right. Well, thank you very much. Appreciate your time.
Thank you.
Well, now we know what it is.